पाय पाय कसं करावं लागेल? पाय पाय करा, भाकरी दे म्हणते मला. भाकरी दे म्हणते ती. हे नवरा भाकरी खायला? ए भाकरी.
Good evening, everyone. So, legends are the embodiment of courage, inspiring others to conquer their fears. So, let's dive into the world where the history's greatest figures becomes your mentor, guiding you through a journey of discovery like never before. Get ready to rewrite the rules of learning and embark on an adventure that simple as it's extraordinary. So this year, MahaAppy comes up with the new rules of learning, launching a new learning platform as a Learning with Legends, where we unite to explore the timeless wisdom and pioneers insights of the medical luminaries. Today, we are privileged to delve into the experiences and expertise of renowned figures in the medical field, sharing the valuable knowledge to evaluate our practices and patient care. Let's begin this enlightening journey together. So, now I request Dr. Amol Pawar sir, Secretary General Maharashtra IIP, to give few words regarding this program.
First, Dr. Ramgopal Chezara, Kashmiri, please. Ram sir, please start.
Yeah. Sorry. I have not seen sir. Sorry. I request Dr. Ramgopal sir, the President MahaIP, to enlighten us with the new program which we have launched today.
Thank you, Dr. Kashmiri. Good evening, friends. Welcome all. And I welcome our first expert of the program, Dr. Nandan Yardi sir. And today's chief guest, Dr. Santosh Kadam. He is pediatrician from Thane and he has just won the election of Maharashtra State IMA President. So congratulate to Dr. Santosh and welcome. Friends, this year we are starting a lot of new programs, 2-3 are in pipeline. So today is the launching program of Learning from the Legends. As Dr. Kashmiri has already elaborated about the program, I am not going to take much time about it. But one thing, we always assure that all the legends from the Maharashtra and all over India, probably you will learn a lot of new things from them. So over to you, Dr. Kashmiri.
Thank you, sir. Now I request Dr. Amol Pawar sir to give their word.
Thank you, Dr. Kashmiri. First of all, welcome Dr. First legend of Maharashtra IIP, Dr. Nandan Yardi sir, who is also chairperson of Neurology chapter of Maharashtra. Then today's moderator, Dr. Jayant Shah sir, today's guest of honor, Dr. Santosh Kadam sir, and Dr. Ram Gopal sir, president. Then all the office bearers of Maharashtra IIP branches, all the executive board members of Maharashtra IIP, and all delegates and PG students. This is an innovative program. The idea came from Dr. Bhavesh Mithia sir, and this is very innovative idea to learn from legends. And the first speaker is from Pune, Dr. Nandan Yardi sir. I had a privilege when I was doing my PG in Pune. I had a privilege to learn a lot during the neurology cases when I was doing my PG at Dr. Ram Dongde sir's institute. So welcome sir, and welcome all delegates again. Over to you, Kashmiri, for further proceedings.
Thank you, sir. Now, I would like to introduce our today's guest of honor, Dr. Santosh Kadam, sir. He is a past secretary of Maharashtra State IMA, past president of Thane IIP, and currently he is holding a post of president-elect Maharashtra State IMA. Over to you, sir.
Thank you, Kashmiri.
Thank you, sir.
Good evening, friends, and welcome you all for this new activity under the able leadership of our President of MahaIP, Dr. Ramgopal Chezara. After a successful conference, MahaPedicon, He has taken over as a MAHA-AP president, and a lot many activities, academic activities are going on. So I guess this is the first episode of new academic activity, that is learning from the legends. And we have really a legend in Dr. Nandan Yardi today, as well as this session will be moderated by Dr. Shah, who is our CIP member of Maharashtra. Equally, our blue-eyed boy, dynamic secretary, Dr. Amal Pawar, treasurer, Dr. Mohan Warke, and par excellence academician, Dr. Bhavesh Mithia will be heading this activity. So I think this will be a successful academic in coming days. I can see already there are almost around 200 members joined for this activity. Apart from this, I came to know that Women's Doctor Wing is doing very well, and Wednesday Wisdom they are carrying very well. Apart from that, the journal reading is going on. Mahakatta activity has been continued, and I think there are two, three more activities in the pipeline, which will be launched by our president, Dr. Ram Gopal Chezara. I guess on the academic front, IIP is doing very well. And since I am newly elected as a Maharashtra president, I have delivered for the problems of the practitioners. IIP is taking care of the academic activity, and IMA is always there for the problems faced by our practitioners and the hospital owners all over Maharashtra. So there are 4, 5 more issues like MPCB, hospital registration renewal, violence, and all these things. So your own pediatrician will be at the helm of affairs at IMA, and I will try my best to take care of these problems. With this, best of luck, and thank you for inviting me.
Thank you, Dr. Santosh.
Thank you, sir. So going further, so for today's program, we have a MMC observer, Dr. Vijay Mandre, sir. So I welcome him also for this today's forum. And with this, our today's moderator, Dr. Jayan Shah, sir, I request, sir, to welcome our today's legends. Over to you, sir.
Good evening, everyone. It's been a pleasure and privilege for me to introduce a very close friend of mine, Dr. Nandan Yardi, and when we see his, Dr. Kashmiri, can you please share his
Yes, sir.
CV
Yes,
slide?
sir. I'm doing that.
When we see the CV slide, we fail to understand where to start and where to end. This is phenomenal. He has been a classmate of mine, and I have seen him since his MBBS days, and I was always in awe with what he could achieve. So Dr. Nandan Yardi is a well-known pediatric neurologist. He is a fellow of American Epilepsy Society. He is also a fellow of American Neurological Association. Let us see, he is editor-in-chief of International League Against Epilepsy, Wikipedia Epilepsy Project. He is a member of so many other things. And he has a chapter in the most important reference textbook on pediatric epilepsy surgery. He has a chapter in that. He is ambassador for India at World Congress on Controversies in Neurology. So he is really at the most global level and at the top level. And we are really fortunate to have him today as our expert legend. And I'm sure we will learn so many things from him in a short while. And he has that knack of teaching many things in short period, and whatever is really practically useful. So Dr. Nandan, I request you to start with your talk, and we'll be very happy to learn from you. Dr. Nandan.
Thank you very much, Dr. Jayant, for these kind words. And what I would do as I share my slides is that I am thank Dr. Ram Gopal Chezara, Dr. Santosh Kadam, then Dr. Amal Pawar, and all the dignitaries who are here. I can see Dr. Dongre sir also, or Dr. Bhavesh, whose idea this is. I can see Dr. Om Prakash Sikchi and so many other dignitaries who are there. It's really a great pleasure for me to be on this platform. Dr. Kashmiri as well. And everybody I can't name, of course, but it's a big team that's working, and I'm very thrilled that I'm sort of here to spend next 45 minutes with you. I think I have 45 minutes or so, in which I will try to cover 3 topics. And I hope I can do justice to the sort of, the theme of this program. And the idea why I've chosen these topics is that these are of practical importance to every pediatrician as the child walks into a clinic, for how you should approach them, what are the thinking behind it, what is the sort of, philosophy behind either treating or not treating. So that's why, and then in the end, I will show you some work that we do in terms of very sort of, a highly advanced stage, tertiary level epilepsy surgery, and how we can change the lives of children. And we have been doing this for the last 25 years. My first patient was in 1998, so practically 25 years follow-up of those early patients. So with this, I think I'll share my screen, and thank you once again for giving me this opportunity, and I look forward for questions. So let's begin with febrile seizures. Can you see my screen?
Yes, sir.
Okay, and am I audible clearly?
Yes,
Because I had
yes,
some
yes.
issue with my audio, so I'm on 2 devices.
And now it is proper.
Okay. Right. I think the slides are now moving. So what is a febrile convulsion or febrile seizure? The definition of NIH CDC in 1980 still holds: an event in infancy or childhood occurring between 3 months and 5, some people say 6 years, Swyman says 6 years, associated with fever, but without evidence of intracranial infection or a defined cause. So any child presenting between 3 months to 5 or 6 years with fever, we have to look for evidence of intracranial infection in the terms of neck stiffness, which may not be there in very young infants, and that's when this usually presents between 6 to 7 months or 8 months. That is the commonest age of presentation of febrile convulsion. And if they are very young, under 1 year, or sometimes people believe under 2 years, and the child looks ill and very drowsy, after the febrile seizure is controlled, then maybe one needs to still do a lumbar puncture. But nowadays, we are not doing so much lumbar puncture. We are observing the child, and if there is some sort of definite evidence that there may be intracranial infection, then of course we need to rule it out. That's the definition. So it rules out all other causes, but just a fever giving rise to a seizure. And the incidence is close to 2 to 3% of all children. But in some countries, such as Japan, it may be 8 to 11%. What is a complex febrile seizure? Febrile convulsion lasting more than 15 minutes with focal features and multiple, that is 2 or more seizures in one episode of fever, which is within 24 hours. So we all know this. 28% of all febrile seizures are complex febrile seizures. 4% are focal. 8% last longer than 15 minutes. 16% have recurrence within 24 hours, and only 0.4% can have Todd's palsy. So even Todd's palsy sometimes, very rarely, can be there in febrile seizure. But when we have a Todd's palsy, I think we must do an imaging to sort of rule out if there is any structural issue there. And this is these are data from the National Collaborative Project, which was in the 70s, and that was a landmark study that gave us all this epidemiologic data. So having understood this, febrile status epilepticus is now defined as lasting more than 10 minutes. So a child coming to you in the clinic where the seizure has started at home, and he comes to you, is supposed to be treated as a febrile status because he has taken 10 or 20 minutes to reach you. And if he's still seizing, that means he is in status and should be treated as febrile status. This is a very, very important concept which has evolved after the FebStat study of Shlomo Shinar, which they did for more than 12 years and followed children who had febrile status epilepticus to see what is their outcome. Now, in general, febrile seizures are very benign conditions. They don't really require much treatment, just good counseling to the parents. But seizures presenting with fever may be part of more sinister syndromes, epilepsy syndromes, that fact needs to be kept in mind. And we have to look for the red flags to look at these presentations and sort of single them out. And those are the ones that need to be investigated or sometimes treated and then counseled, because they are syndromes and they'll have a natural history, certain age of onset, certain type of presentation, which we will look at as we go on. So what are really the issues in febrile seizures? Can prophylaxis of febrile seizures prevent subsequent epilepsy? And these are the questions which your patients or parents will ask you. Can anti-epileptic drugs, now we call them anti-seizure medication, they are not known as AEDs anymore, they're known as ASMs, because really all these drugs stop the seizures and they really don't act on the process of epilepsy. Therefore, they're not anti-epileptogenic drugs. So they're not really, the new term internationally is ASM, And I think we should all adopt that. So can ASMs prevent recurrence of febrile seizures? So do we give them a long-term thing or not? What is the frequency of complications and long-term side effects of prolonged anti-epileptic medication in very young children? What are the factors that predict later onset of afebrile seizure or epilepsy? These are the questions that we have to answer. And what is the relation of perinatal events and febrile seizures? Is there all this? We're going to be discussing this. So you will get answers to all of them. And that's what you'll have to tell the parents and sort of counsel them. What is the effect of febrile seizures on behavior and intellectual outcome? Is there any correlation with this? So febrile seizures and epilepsy are different entities, as we know. And following a febrile seizure, the risk of recurrent febrile seizures is 34%. So once a febrile seizure, there is a almost 1/3 chance that the child may have another recurrence. Febrile seizures below 1 year, the recurrence rate is high, 50%. Above 3 years, it drops down to 20%. So therefore, the age at which the child presents to you, you can tell them about the recurrence chances. Okay. And the risk of later epilepsy in later life is only 2 to 3%, as we have said. So it's really a benign condition, only 2%. And actually, in a general population of adults, it is 1 in 200. So it's approximately the same kind of, it's 0.5 to 1% in an adult. When there is a febrile seizure, the risk is only 2 to 3%. So it's not a very big risk, grossly a benign condition. So what are the factors predicting the condition that differ? Recurrent febrile seizures are occur when there is young age at onset and family history of febrile seizure. So you must ask this history. How young is the child and is there a family history? If there is a family history, he is likely to get more recurrent. If there is no family history, if it is an older child, 3 years, as we saw, less than 20% risk, you can reassure the parents. Epilepsy after febrile seizures, what are the chances? When there is prior neurologic abnormalities, like a child is mentally retarded or delayed or has some kind of a neurologic deficit, if there's a family history of epilepsy. Now here there's a difference. For recurrence, it's a family history of febrile seizures. For getting epilepsy after febrile seizures, is the family history of epilepsy. So if somebody has a history of febrile seizures in the family, it's not a risk factor for getting epilepsy after febrile seizures. And of course, if a child has had complex febrile seizures, then he has slightly more risk, not 2 to 3%, but close to 7%. So this is how we counsel the parents based on just on the history, looking at the age of the child. So Alan Hauser did some epidemiologic studies, and he found that febrile seizures do not add to the risk of epilepsy in those children who already have an MR or cerebral palsy. So we do get these children who have MR or cerebral palsy, then come with a febrile seizure, and we tend to think that they may have higher risk, but there has been no statistical difference. Therefore, we can reassure the parents. Why fear recurrences? 10% of recurrences are prolonged, lateralized, or repeated in the same illness. Therefore, they become complex febrile seizures. It's a risk factor for subsequent epilepsy. If many febrile seizures occur, chances of epilepsy are increased. And children with recurrence fail to develop DQ over 2 years. This is shown by Lady Sheila Wallace in 1982. So, is there a genetic factor? Because parents are going to ask you this. Studies have shown that there are genes for febrile seizures that occur with higher frequency in those families with other generalized epilepsies. Families with benign Rolandic epilepsy, what is known as benign epilepsy with centrotemporal spikes, which is seen in slightly older children between 4 to 7 years, seizures occurring only in sleep, usually affecting the mouth and the upper limbs in terms of sensations or twitching of the mouth. And in Sam Berkovic from Australia studied twins with febrile seizures, and he, based on this, said that yes, there is a genetic effect because of which, so basically febrile seizures is a genetic disorder. And twins discordant for febrile seizures have shown no differences in cognitive development. So one twin had febrile seizure, the other did. Their cognitive development was the same. Therefore, Schwartz-Christensen showed that there is febrile seizures do not affect cognition or mental outcome in general. Gene for febrile seizures like Feb3 has been mapped to 2q chromosome 2324 in a large family in Utah, and this was shown by Pfeiffer. So what are the mechanisms? Why do children get febrile seizures? So exogenous pyrogens, because of whatever infection, actually affect the hypothalamus. Increased ACH, acetylcholine release is there. There are nicotinic receptors which are upregulated, and this affect thermogenesis. And this thermogenesis that occurs, it leads to an upward setting of thermoregulatory center, and therefore the brain becomes more susceptible to excitation and a seizure. Further, various inflammation. Now, these are all the new theories. Those were the old theories. The various inflammation associated genes are studied. Interleukin variants are known, IL-6 and others. Some are protective and others increase susceptibility to seizures. And there are certain alleles for interleukins which are found. So there are alleles. There is also known as TFGB genes. These are when some haplotypes and genotypes are increased in febrile seizure patients. Of course, in our country, iron levels are low in great proportion of patients. In the US, it's only 1% of children. We have much more than that. You know better. And this leads to abnormal myelination and neurotransmitter activity. Low zinc and selenium, which are essential cofactors disrupting metabolic processes and synapse activity, is also very important. And these are the ones, all factors and modulators of getting febrile seizures. So what are the issues in febrile seizures? Can prophylaxis of febrile seizures prevent subsequent epilepsy? Why not treat all febrile seizures with prophylaxis? There is no consensus on this. Can anti-epileptic drugs prevent recurrence of febrile seizures? Phenytoin, carbamazepine, definitely no, and may actually aggravate, and they can cause sometimes in children behavioral abnormalities, autistic features. So phenytoin, carbamazepine should never be used in febrile seizures. If the febrile seizure is not a regular febrile seizure, and if it's a SCN1A abnormality,
దీనికోసం చూస్తాం మీరు కూడా అన్నా కదా స్పీకర్
like a FCN1A abnormality like a Dravet syndrome, then it will exacerbate the seizures and the manifestations of Dravet syndrome. Therefore, all sodium channel drugs like phenytoin, carbamazepine should be not be used in febrile seizures. Phenobarb, not useful. It has significant side effects in terms of memory, behavior, and hyperactivity. Valproate is useful. And diazepam is also effective, but we don't use diazepam so much unless we use it as an intermittent diazepam, and we'll come to that. So what is the frequency of complications and long-term side effects of prolonged anti-epileptic medication in very young children? 20% with phenobarb, and with valproate it is rare. Therefore, we don't use phenobarb anymore, and valproate we do use whenever required. And when to use, I will tell you. So what is the relation of perinatal events and febrile seizures? Adverse perinatal events have no significance. We saw that with the MR and CP that it did not significantly increase the chances of later epilepsy, nor does it have effect on getting or not getting febrile seizures. What is the effect of febrile seizures on behavior and intellectual outcome? We saw from the twin studies and long-term studies that no significant difference. So these are all the things that you will have to talk to the parent, even when the child comes first time with a febrile seizure. And especially when children come with recurrent febrile seizures, you have to stress these points and sort of reassure the parents. What are the factors that predict later onset of afebrile seizures? We saw that abnormal neurologic examination, family history of epilepsy, and complex febrile seizure. So I hope I have addressed these issues of the philosophy of febrile seizures, that they are benign, and only sometime we should look for the abnormal red flags and then work them up. So in the management of febrile seizures, not too many investigations need to be done here. Often we don't do EEG because EEG should not be done in the first 1 or 10 days to 2 weeks, because you might get some transient abnormalities and they get reported as abnormal, and then they children go on to anti-epileptic drugs for no reason. And we saw that there is no reason to give the long-term anti-epileptics because they have 20% chance of side effects with phenobarb and some side effects with valproate, especially related to the liver and pancreatitis. So first scenario is when a child presents to hospital or your clinic with a seizure that has happened and stopped. And they come there. By the time they reach home, reach the hospital, most of the seizures last 2, 3, 4 minutes and they have stopped. Just check for signs of CNS infection. If everything is okay, there's no neck stiffness, the child doesn't look very ill, he's just postictal, reassurance, discussion of recurrence and future epilepsy should be done with the parents and the child sent home. Scenario 2, child comes at casualty with ongoing seizure. The seizures are still going on. Therefore, by definition, lasting more than 10 minutes, it is status epilepticus. We use intranasal midazolam or buccal midazolam. It can be sprayed in the nose or in the buccal region by opening the mouth. 0.2 to 0.3 mg per kg spray is used. Or in America, they use rectal lorazepam or diazepam known as Diastat. And these are the doses that are given in the textbooks. And repeat doses may be given either of midazolam or this thing. And this pre-hospital, actually, we give this to the parents now. when already child has had one febrile seizure, we arm the parents with this, say that you do give it at home so that it does not progress to a status, and most of the seizures stop at home, and then they have to just inform you that the seizure happened and it stopped. They can come to you next. If there is no response to a repeat dose of midazolam or these medications, which is the primary medications, then you have to treat it as per a status epilepticus protocol, which is run in your hospital or unit. Every hospital or unit has its own protocol. Some things are given earlier, some things are given later. So we go by that protocol. Scenario 3 is that recurrent febrile seizures or focal febrile seizures, or febrile with afebrile seizures. So if you have focal seizures, it is complex. Recurrent febrile seizures is complex. And febrile seizures and afebrile seizures occurring at different time in the same patient, that's a red flag for some kind of a channelopathy like Dravet syndrome, PCDH19, which is seen in girls with mental retardation and resistant epilepsy. And what is known as febrile seizures plus is the febrile seizures that occur outside the defined age, that is less than 3 months and more than say 5 or 6 years if it occurs. So a 9-year-old child coming with febrile seizure is febrile seizures plus. So these are the ones that is the next scenario, and these have to be worked up to make sure with EEG, sometimes if there's focal seizures with MRI. So what are the treatment options that we have? Long-term phenobarb is not effective in more than 30% of patients with febrile seizures, so not really given. It causes irritability and cognitive effects. Valproate is effective, but it has liver toxicity and pancreatitis, so it should be used with great caution, especially in young children under 2 years. Intermittent clobazam is the best. We give 0.5 to 0.75 milligram per kilogram dose orally, and you give it at the onset of fever. Fever more than 99 degrees central, we tell them to start with 0.5 mg per kg per dose stat and given every 12 hourly. And we usually stop and also give antipyretic. Maybe sponging helps. It's really something for parents to do so that they are busy sponging the child, they don't panic. Otherwise, it has not a major role. Antipyretics may or may not be useful. There's no definite consensus, but when there is fever, we have to bring it down. Whether that affects the febrile seizure or shortens the febrile seizure, really nobody knows, but that's all that parents can do. And if the child actually has a seizure, we have the midazolam which the parents can administer at home. Clobazam is given 12 hourly. We usually tell them to give it till the fever lasts, and after the fever has gone, we stop the antibiotics. Still, we give intermittent clobazam for 1 or 2 days extra to make sure that there is no 12-hour gap or 16-hour gap and the fever comes back and the child gets a seizure. Generally, most febrile seizures occur on the rising fever or early onset at the early part of the fever. It is not usually that child had 6 days fever and on 7th day got a febrile seizure. So that's why we say continue clobazam for a day or so, 2 after the fever is gone, and then stop. So with that, I think I come to the end of this first one, febrile seizures. And I think I will move on to the next one. Let me see how I can get my other presentation. Okay, can we go on to seizure mimics?
Yes, please.
Yeah. So now the other problem that you face when the child comes to you in the clinic, or nowadays they come with videos, home videos, is that there was some kind of a shaking in a child, some movement, and you have to determine whether it's a seizure. They say that the child had a seizure, but half the time or more, very often, these are not fits, and we have to be able to differentiate. So if you look at, can you see the screen now?
Yes.
Yeah, so now I'm going to turn on the video and look at this infant. Look at the feet. There is a tremulous movement, and when the pediatrician or the doctor there holds on to it, it stops. So this is tremulousness. We all know that. Very common in neonates. Okay. Then that is the most common one. So that's how you differentiate, and you don't have to treat tremulousness. Tremulousness may be related to calcium deficiency and so many other metabolic reasons, or just a irritable child who has had some asphyxia in the initial part can have some tremulousness. And now with increasing use of substance abuse, mothers who have had substance, their children will present with this kind of a thing, which is very severe. It really doesn't stop with anything. Then breath holding spells we all deal with. They could be pallid spells or cyanotic spells. Cyanotic spells is when there is a cry, then holding of breath, and then the child becomes loose, hypotonic, the neck drops, and then there is a cyanosis. So here it is provoked by upsetting or scolding an infant. Brief shrill cry followed by forced expiration and apnea. Rapid onset of generalized cyanosis or loss of consciousness can occur. May be associated with repeated generalized tonic jerks, opisthotonous bradycardia. So bradycardia is known, and that's how they get the cyanotic spells. EEG is normal and rare before 6 months, peaks about 2 years to abate by about 5 years old. And all you need to do is parent counseling and behavioral therapy, that the child should be ignored when he throws the tantrum and cries, and should be told at other times that if you cry, we're going to put you down, we're not going to look at you. So that kind of behavior sometimes helps and it goes away. Some people have tried some things like piracetam, which is empirical. The pallid spells are again initiated by usually a painful experience, some kind of an injury or something like that, a fall. Child stops breathing, cries, stops breathing, there's loss of consciousness, pale and hypotonic. And tonic seizures can sometimes, 1 or 2 jerks can occur, or there is a stiffening or a posturing over here. Now, this is not to be mistaken for seizures, because there were studies of some German adolescents who were made to do Valsalva maneuver. I think they were German or British, I'm not very sure. I think they probably British. Young people who were made to do Valsalva maneuver, they all dropped down on the mat after Valsalva, and many of them had clonic movements, and they were not seizures. So you can get some clonic movements in this. Bradycardia with asystole for 2 seconds may be recorded sometimes. EEG is normal. Treatment is supportive, but sometimes some may give atropine sulfate at 0.01 mg per kg per hour in divided doses with a maximum of 0.4 milligram. Or atropine substitutes could be given to some of these kids, but we usually don't need them. So syncope we already discussed. Decreased blood flow, loss of consciousness, ischemia influences the higher cortical centers to release inhibitory influence on the reticular formation within the brainstem. So whatever happens, extreme emotion, pain, whatever, extreme exertion, all these can cause simple syncope, and brief tonic contractions of muscles can be seen. Results from vasovagal stimulation precipitated by pain, fear, excitement. These are the precipitants. This should be avoided if possible in treatment. Prolonged standing, particularly in a warm environment, clustered claustrophobia, and all these can give rise to syncope. Usually seen between 3 to as old as 25-year-old, common in females. The tilt test may be done, effective in producing symptoms including hypotension, and that proves that it's syncope, tilt table test. And oral beta-adrenergic blocking agents could be used if they don't respond to taking adequate fluids. A lot of people don't take adequate fluids, don't have adequate sleep, they are highly stressed. So all those things have to be discussed, and the lifestyle management is now very important for this. Otherwise, beta-adrenergic blocking agents could be used for a short period of time. Now, there is something known as a cough syncope, most common in asthmatic children, occurs shortly after sleep, and there is a coughing paroxysm that awakens the child from sleep. Patient becomes, the face becomes plethoric, he perspires, he gets agitated, frightened. Most of it is probably because of the hypoxic element which is there with in asthmatic children in sleep. That hypoxic event is probably compounded by the sleep. Loss of consciousness with generalized muscle flaccidity, vertical upward gaze, and clonic muscle contraction lasting as several minutes can occur. And urinary incontinence also occurs with this. And if you look at the EEGs, it is normal. Why this happens is cough causes an increased intrapleural pressure, decreased venous return to the right side of the heart, decreased right ventricular output, reduction of left ventricular filling, rapidly diminished cerebral blood flow, cerebral hypoxia, and loss of consciousness. And the treatment is prevention of bronchoconstriction by giving bronchodilators and other respiratory hygiene, and prevention of allergens that can give rise to these asthmatic things. Syncope because of prolonged QT syndrome is another thing that we must look at. We must auscultate for all children who have syncope. We must also probably do a long lead ECG to look at QTC intervals. That is a corrected QTC, QT corrected interval. So sudden loss of consciousness during exercise or emotional and stressful experience. Late onset childhood or adolescence is the time that this occurs. Cardiac arrhythmias occur, such as ventricular fibrillation, that may be recorded on ECG. Then ECG shows abnormal lengthening of the QT interval. The corrected QT should be less than 0.46. But if it's more than 0.646 or 0.5, that's an indication, and this can be seen in families of patients. May be associated with acquired heart disease also. So all children with acquired heart disease who have syncope should be evaluated in this fashion. Autosomal recessive trait, what is known as Yerwell and Lange-Nielsen syndrome, is associated with deafness. So ask for a history of deafness in anybody who has syncope, really speaking. And autosomal dominant, which is known as a Romanov-Ward syndrome, is also another one. Mutations in cardiac potassium channel gene linked to chromosome 11 are found in some of these patients. LTQ1, LTQ2 results from long QT1, long QT2 results from mutation to second potassium channel gene linked to chromosome 7. So there are two chromosomes, chromosome 11 and chromosome 7, which are responsible for these abnormal latencies in the heart that give rise to cardiac syncope. And the treatment is really referring to a cardiologist and getting treated from them. The long QT3 results in mutation in cardiac sodium channel linked to 3p21 and 21-24, and long QT4 is linked to chromosome. So there are 4 syndromes which are linked to long QT intervals. Testing include supervised exercise test or Holter monitoring. So if you suspect a cardiac cause, if there is some ECG abnormalities, then you go for Holter monitoring or send him to a cardiologist for exercise supervised testing. Treatment is with beta-adrenergic antagonist drugs. Permanent implantable cardiac pacing may be required. Left thoracic sympathectomy may be considered if drugs are not effective. And parents, of course, should be taught good CPR because that can be life-saving. So there are a lot of these things that appear to sort of, faint or have funny turns, but they are not epilepsy. And this needs to be very, very clearly defined and differentiated, because otherwise you'll be treating them with anti-epileptic drugs with only side effects and no effects on the basic pathophysiology that is causing all this. Now let's look at this child. What do you think he has? So there are sudden jerky movements of the entire body which go on like this. And this is what is known as paroxysmal kinesogenic chorioathetosis. Now, what is this? Sudden onset of unilateral or occasional bilateral chorioathetosis or dystonic posturing of a leg. They may not have the chorioathetosis or these jerky movements that he has, but it just could be dystonic posturing of a leg, arm, or just a facial grimacing and dysarthria. It is precipitated by sudden movements, excitement, or stress. Rarely lasts for more than 1 minute. Onset is usually between 8 to 14 years, but this kid was about 4.5 years. Attacks may be daily or intermittent. Paroxysmal kinesogenic chorioathetosis has prominent chorea. Otherwise, we call it paroxysmal kinesogenic dyskinesia when there is no chorioathetosis. Neurological examination is completely normal other than these movements that are seen. MRI and EEG is usually done to rule out in all these movement disorders. MRI and EEG are normal. It's an autosomal recessive inheritance that is suggested, and these are treated with phenytoin and respond very well to phenytoin. Now look at this kid. Can you see the videos well? I hope. Look at what he's doing now. Look at that. What do you think this is? So this is what is very common, and they come with these videos and say, "To asa karto, asa hadarल्यासारखं करतो." And usually it's that as a reaction to somebody whom they see, the father has come from office and he sees him, he does this. So those are all normal emotional reactions. But if this is happening again and again, without any such provocation, it's known as a shuddering attack, where the child actually just shudders. Usually seen in very young infants, 4 to 6 months of age, and it passes off after a particular time. And sudden flexion of the head and neck and or shuddering movements or shivering movements can occur. And this may be a precursor to benign essential tremors in later life. So this should not be missed, and this need not be treated. Now look at this. Video appears very funny. Look at this boy who is sleeping with one parent on his side. I think it's his mother or somebody. Look at what he does. He is fast asleep. He wakes up. Now, this could also be mistaken as epilepsy. It could be like a frontal lobe seizure. But he does this every night and sometimes even in the afternoon sleep. And he is not aware. And people are scared of him. So, this is what is known as night terrors in small children, older children, also varieties of parasomnias, meaning that abnormal movements in sleep. And these are common in boys 5 to 7 years of age, but can occur in much older and even in adults, older kids, adolescents, and adults. There's a sudden onset between midnight and 2 a.m. during stage 3 or 3 of sleep or slow wave sleep. That means it occurs in deep sleep. Child screams, appears frightened, dilated pupils, tachycardia, hyperventilation. This is what is night terror. Child thrashes violently, cannot be consoled for minutes to hours, unaware of parents or surroundings, and then he goes to sleep. In the morning, he does not remember this episode. Those are night terrors. And what I showed you are parasomnias, which are abnormal body movements occurring in sleep. And there are various sleep disorders where you get parasomnias. We will not get into that. 1/3 will have somnambulism or somnology, where they will either walk in sleep or talk in sleep. Emotional disorder should be explored in a patient with prolonged and persistent night terrors. Short course diazepam may be considered while the family dynamics is being investigated. So usually it may be secondary to some kind of a abnormal family dynamics and abnormal family psychopathology, where there is some disruption in the interpersonal relationships in the family. Now, coming to benign paroxysmal torticollis of infancy, as the name suggests, it is basically a paroxysmal torticollis occurring only at some point of time with the torticollis of the neck, recurrent attacks, head tilt with pallor, agitation, and vomiting. So, just head tilt can be like a tic disorder. Some kids do that. Some kids also raise the shoulder or blink the eye, and they are all probably simple tics, or sometimes a bigger syndrome like Guillain-Barré syndrome. So they should be looked at from that angle. Agitation and vomiting actually pins it down to the benign paroxysmal torticollis when the torticollis occurs along with this. Usually seen in young kids 2 to 8 months. Spontaneous remission occurs by 2 to 3 years. Abnormalities in vestibular function are noted, and that's the reason why they get the torticollis. Some patients develop migraine in childhood. So there is some link between vestibular function, migraine, torticollis, not only in children, but sometimes even in adults. Now, other two things are narcolepsy. EEG shows recurrent sleep attacks. That means during daytime, there are excessive daytime sleepiness and naps. Dewe-Gowda syndrome consists of REM sleep, and patients are very easily aroused from that sleep. Treatment for narcolepsy is modafinil acetamide, 200 milligram a day. And in children, the dose may be lower. Cataplexy is where a person laughs, and suddenly gets a drop attack, like a sudden loss of muscle tone, falling to the floor precipitated by laughter, stress, or a frightening experience. So treatment is to take scheduled naps. Amphetamines may be used. Methylphenidate is used more commonly, and tricyclic antidepressants may be used. Counseling regarding occupational safety is important because they can be laughing in any situation and fall from there. So if they're on balconies or in treks or something, they have to be careful. And rage attacks or episodic dyscontrol syndrome can sometimes be seen, especially in mentally retarded children, autistic children. Children who have special needs are given medications like for hyperactivity. They suddenly have episodes of sudden and recurrent violent behavior with minimal provocation. They seem to be psychotic at the time of attack, but they otherwise, when they're quiet, are normal. And then their EEG tends to be normal. So these are the various things that we see as. Now, what do you think this is? Look at this gentleman. He began these episodes when he was a young kid. He had difficulty in swallowing, and he would have some throaty noises. And look at this bizarre. Now, do you think this is just an abnormal movement disorder, or is it an epilepsy? So in fact, this is an epileptic attack because they're absolutely stereotyped. And then he is not responsive at the same time. And with this, I think I end the second part of this discussion, which was how to look at what shakes and where they lose consciousness, and whether these are how to look at them, how to determine, ask for home videos, which are epileptic, which are non-epileptic. And I will now go on to the next presentation, where I will show you what we actually do with some difficult cases. These are tertiary level epilepsy surgery cases, and I'll just take 10 minutes to give a brief idea of what we do. And we've been doing this for the last 25 years. Yeah. Now, this is a case of a 22-month-old infant. She was born of a full-term normal vaginal delivery and had good Apgar score. All development was normal. She had bisyllabic speech at 1 year, walking by 9 months. Seizure started at age 17 months, which are noted by parents. Just give me 1 minute. Yeah, so noted by parents. The habitual seizure consists of an aura. She understood there is something happening. She would come running to the parents and sometimes she wouldn't get an aura, but she would get a behavioral arrest where whatever she was doing, she would just freeze and stop with bilateral hand automatisms lasting a few seconds, clustering many times a day. And she got about 25 to maybe 30 seizures or 40 seizures in a day. So it was very frequent. And she had also started sort of losing out on language and development around this time. And this would last for 15 to 5 to 20 seconds and would cluster on any given day multiple times a day. Let me make this full screen. Right. Now the seizure, typical seizure I'm going to show you. I hope this works. Look at this kid. So she has got a behavioral array. She's got some typical posturing which is there in the first and even the second, even the third one. You see the right arm is flexed and the left arm is extended. So it was stereotyped, and this lasts 15-20 seconds. The second one again is similar. Look at that. Third one is also similar. Right arm flex, and it's about 15-20 seconds. Then she's absolutely fine and laughing at the end of this. So ASM use means anti-seizure medication use and course. She initially had consistent eye contact and socialization, which deteriorated over time to become inconsistent along with ADHD that she developed, and lost language to some extent. Valproate, clonazepam were given. The other drugs prior was oxcarbazepine, levetiracetam, clonazepam for next 5 months with multiple clusters of seizures 20 to 30 times a day. She had a normal neurologic examination, no neurocutaneous markers. Her scalp EEG actually showed a good background with no asymmetry or spike wave discharges. So there was nothing seen on her surface EEG. 2 intricate EEGs recorded showed in wake and sleep were normal. So we did a sleep EEG, we did a sleep deprived, everything was normal. MRI showed, was reported as normal, but actually showed an ill-defined focus as hyperintensities on T2 weighted and flare images, which I will show you now. And it was reported that there were some bilateral periventricular regions were abnormal due to gliosis or hypoxic ischemic encephalopathy, which was not there because she had a good birth history. So that was a red flag. Now this was the MRI that was shown. And if you can see the arrow over here, these are reported as normal. But if you look here, there is a slightly brighter area here. If I can enlarge the screen, and you can see that, look at this. Compared to this one, this is more white, little bright. I don't know if you can appreciate it, this and this, right? So I'm going to go back to the original size. And if I enlarge this image, now you can see that there's a difference. There's more white hyperintense area around here in the sort of frontal area medially, as compared to the right side, as compared to the left side. Left side is normal. And here, if you look at this design of the white matter is different over here. And you find that there has been some gray. This gray and white is very distinctly separate, and this is fuzzy. So there is something like a focal cortical dysplasia going on over here, and that probably is a reason for the seizure. So this was the thing. So we did her video in my clinic, and I'll just jump to where she gets her seizures. She's lying down. This is a typical stereotype seizures which you would get. Look at that. She gets an aura. She keeps the phone away. And look at the face. The face is drawn like this. Face is drawn like this. Like this, down. So this is known as a caput the gendarme. Means that is the mouth of a French policeman, because when they approach, a policeman approach you in France, he has that, expression on his face where he looks at you and says, yes, why were you over speeding? That kind of an expression. So this is very typically a sign that says that the seizure originates in the cingulate cortex. That is the cortex right above the ventricle. Okay, so that gave us, the video EEG gave us the localization, and these are the type of seizures. So again, if you look at that on the right side, F4C4, that is a medial part of the frontal lobe, shows these spikes over here, this area you can see. And this is what we saw. Again, there are spikes in the frontocentral region, right? So again, that was localizing. Then we got a PET scan done. The PET scan again shows the same region over here. This region which we showed, this one in the MRI scan on a coronal section, the same area looks here, which is showing like this, and our PET scan looks like this. Now we co-register these images one on top of the other. That is the PET scan on top of the MRI are co-registered in this Medtronic device. And you find that on the right side, that is where the problem is, this one here. And this is the fiducial marker that is seen going down, and that shows the same area. But whichever cuts you take, it points to the same area. So therefore, that was the focal cortical dysplasia. So we took her up for surgery, and we opened, craniotomy was done. This is an electrode which is placed on the surface of the scalp. We did the recording, and then we mapped out the area from which maximum seizure discharges were occurring. So these are the 4 points or 5 points which are marked where all the discharges are occurring. We do intraoperative electrocorticography, and then we also put in a needle which inside into the depth of the electrode to see how deep is the electrical discharge, right? And then these are the recordings, the superior frontal gyrus, the interhemispheric recordings. These are all showing big spikes over here. Look at these spikes, these big spikes. Can you appreciate them? So this big spike here. So these spikes were there. So that's how we located where the area is. So we have to find out an area. So we found a ice cream cone shaped area with the top of the ice cream cone over here. This is the needle electrode been put inside. It has got 4 different contacts. So up till which contact do you get the discharges can be seen. These are the depth electrodes, and this also shows spikes over here. Can you see these spikes? So we record like this, and finally that ice cream cone shaped area which was in that same region which was there is removed. Look at this, and it's an ice cream shaped ice cream cone shaped area that we removed, and this was actually the supplementary motor area of this child. Now, supplementary motor area, as we know, is not the main motor strip, which is on the homunculus, but this is an additional motor area subserving some motor function. So we knew that when we remove the right side, she's going to get a left hemiparesis, especially of the leg, because the leg is represented medially and the tongue is represented laterally. So we took this consent in writing from the parents. It turned out to be a focal cortical dysplasia type 2B. It was sent to NIMHANS, to the top neuropathologists. And this is the post-operative on day 1, next day, post-op day 1. And look at this. This child is now on post-op day 1. She is moving her right side. Of course, we look for paralysis on the left side. The left foot is lying like this, flaccid. But she's able to watch the movies. She's able to interact. She's able to speak. So there is no deficit other than this lower leg, which was expected. Even then, to some extent, she's moving it a little bit, not with grade 4 power, but grade 2 plus or something. She's moving it. This was day 1. And now, 1 week later, she came to my clinic, climbing up the steps, and you can see what her condition. She is able to run now. Left leg is still a little paretic, the way she runs. Can you see that? Yeah. And then 1 year later, she is back in my clinic, completely all right, going to school. She is able to read and write. Seizures have gone completely. Ever since the day of surgery, she has not had a single seizure. Now it's more than, I think, 2 years. And she takes complete activities, takes part in all activities in school. This is some school program where she's done. So that is the type of surgery we do that is known as eloquent cortex surgery, where the cortex actually has some important function. And we actually removed part of the cingulate gyrus and the frontomesial cortex, just as in this paper, with a very good outcome. No deficit. There was a deficit. We told them it might last 3 months, 6 months, but it's going to recover because child's brain has plasticity. And because of that plasticity, the child can actually recover. Now, I think I'll stop in 1 minute. These are all the studies and the things, outcomes and all that, which are, and this boy whom I showed you, I'll just end with this, who we were wondering whether it's some kind of abnormal movement or seizure, actually had this abnormality, gliotic abnormality here. And this is known as a Kuznecki syndrome, where you have polymicrogyria and subcortical nodular hypotropia. That is an abnormal tissue. It's kind of an abnormal brain tissue in this region. And that usually presents to ENT surgeons with swallowing difficulty. And that's what happened to him. But when he started getting these seizures, he was being treated. He had to go with his mother everywhere. He couldn't be left alone. He used to get 10 to 15 seizures a day. And this was, I think, 2001. We operated him. And 2001 and 2004, we operated him. Since 2004, this is a mistake here, 2004 onwards, he's been seizure-free completely. In those early days, we did a functional MRI to look at where his motor activity and speech is. And we found it to be on the opposite side because although he is right-handed, his speech area has shifted to the opposite side because there was damage on this side. This whole area was resected and he's been seizure-free. He started moving around independently. I think with this, I'll stop here and I can take a few questions because otherwise we'll run out of time.
Thank you so much, Dr. Nandan, for this so informative talk, right from practical things which we see in the OPD every day to right up to the latest advances. And it has really been very enlightening for all of us. I see a few questions in the chat box. One is, it says, can we use nimesulide in babies more than 2 years to reduce the temperature? And I think nimesulide in pediatrics is not advocated, but what is your answer?
I don't think it is advocated, although some people do use it. Paracetamol in good doses is effective, but sometimes it is not with these viral infections and some other fever. So ibuprofen, ibuprofen, and its combination can be used. Sometimes even a meftal, mefenamic acid can be used. So those are safer than nimesulide because there have been cases of severe side effects with nimesulide.
Yes. And there's one more question. If there is no consensus on prophylaxis of febrile seizures, why does the IAP recommend clobazam prophylaxis?
Yeah, that's a very good question. Now they have shown, they have done various studies on prophylactic treatment of febrile seizures. And it is not found to be 100% protective. So at least in more than 30 to 50% of the patients, it may be useful rather than not giving anything. And therefore, we do recommend that. Second thing is it is safe. Clobazam usually does not have any side effect, just as some of the other ones. Even diazepam probably makes the child more drowsy. Clobazam does not even cause significant drowsiness. In fact, in some children, it may cause a little bit of insomnia in those children. So therefore, being safe and having a 30 to 50% sort of evidence that compared to placebo, there have been studies that it shows significant but not very conclusive difference. Therefore, it is not only by IAP, even AAP also recommends it. And I think even the International League Against Epilepsy recommends it as a prophylactic.
Thank you, Nand. And we have to give something to the parents also for the
that of course. And then that's what I said. Sponging and antipyretic. There is no very conclusive consensus about that. Giving antipyretic actually prevents the febrile seizure. So there is no study which really shows that. There have been few studies which have shown some very minor statistical differences, but there is nothing very conclusive as compared to that.
Giving absolutely nothing to the parents, that will increase the anxiety in them.
Yes. Also, they have a feeling of guilt, I should have done this, I should have done something. So so that also is taken care of.
Yes, thank you. Any other questions?
Dr. Bhavesh, unmute yourself. Dr. Bhavesh, you have to unmute. You can't. Pallavi, please unmute Dr. Bhavesh. I'll try from my
Yes,
end.
he can unmute, sir, now.
Dr. Bhavesh, now you
Yes,
can.
sure.
Yeah, I think he has done it.
Now
Yeah,
I can.
Yes,
Okay,
yes,
there are a couple
yes,
of other questions in the chat box.
sure.
One is the question from Dr. Vilas Salure that in what all conditions the neurosurgery useful to control the seizures? Like the couple of cases what you had
Okay.
showed.
Okay. Now, I showed something which is really operations of eloquent cortex. But most common thing is a mesial temporal sclerosis, which usually is often precipitated by a history of prolonged febrile seizure. Again, there is no very definite relation to prolonged febrile seizure, but there's an association. There's no proved theory, but there is a significant statistical association that people who have mesial temporal sclerosis also had prolonged febrile seizures in the past. And what they present as is temporal lobe seizures, where the person gets an aura, usually an abdominal sensation that rises up in the chest, and then it goes to the head. And then he says, I don't know what happens to me. Then he loses consciousness, of course. So it's a simple partial seizure beginning with an abdominal aura, becoming secondary generalized or spreading to the remaining part of the brain. That's where he loses his consciousness. And then he can have chewing and swallowing automatisms, that kind of a thing. And then he has some hand bilateral or unilateral automatisms, then turning of neck to one side, posturing of the limb on the same side. And these are the type of complex partial seizures or focal unaware seizures, what we call. And their MRI should be done. CT scan will not pick it up. So the investigation of choice is MRI. And that too, if you can do a 3 Tesla or at least a minimum 1.5 Tesla MRI, it will pick up a sclerosis on the medial part of the temporal lobe. Now, this is the most common surgery and has a very good outcome of 80-85% seizure freedom. Or maybe 5% or another 5% of patients will have rare seizures while being on anti-epileptic drugs. So this is the most common. Other than that, the next common is if there is any lesion in the brain, which is where we can prove that the seizure comes from that lesion. And it's usually has to be a single lesion. If there are bilateral lesions, if there are multiple lesions, then the effectiveness of the surgery becomes much, much less. So as we talked about mesial temporal sclerosis, 85%, if you do lesions which are single, you can get 60 to 70, 75% seizure freedom. But if there are bilateral or multiple lesions, it drops to 25% or 30% at the best in the top centers in the world.
That exactly the question of Dr. Sushma Sabe, that the role of a surgery, if there is a bilateral focal cortical dysplasia, if it is a bilateral cortical focal dysplasia, outcome and the indications.
So if the very broad cortical dysplasias, it depends, even if it's bilateral, it depends on what area it is. If they are on eloquent areas, you generally can't, even single one is very difficult, but we do it with all due care and with some due risk of some deficit. But children's brains are very plastic. So even if there is a sort of brief deficit for a few months, the rest of the brain areas will take up these functions, even motor functions, speech function, other functions, memory functions can be taken over by other areas. So children are better candidates for surgery than adults. In adults, if you take out, there's hardly any plasticity, so the function will not be taken. So, but bilateral focal cortical dysplasias generally have poor outcome. They'll continue to have seizures. They'll undergo all the risk of surgery, the cost of surgery and everything, and still have to take anti-epileptic medication, still continue to have seizures. So the outcomes are not very good. And you sometimes have these, bilateral polymicrogyrias and all those big ones, which are more diffuse. So whatever is seen to the eye and whatever is seen on the MRI is removed, but underlying the rest of the brain also has these abnormalities, and those are not going to come out because you're going to only remove the lesion that you see on MRI. So it is more complex than just seeing a lesion and removing, and therefore the cases should be worked up extremely carefully to get a very good outcome. If you just go on operating all cases here and there just because there's a lesion, your outcomes are not going to be good, and it's not really recommended anyway. Does it answer your question?
I think so. And Also, this is my personal question to your first quiz, where you showed the surgery of around 3-year-old girl really made a difference.
Yes,
So in the her seizure simulology, she was kind
yes,
of trying to use her right hand touching towards the forehead and kind of
yes,
all the time
yes,
it was always a right hand.
yes,
Incidentally, her MRI also showed the lesion on the right side.
yes.
So
See
I was not able
yeah.
to understand the
So I'll
correlation.
tell you that. I'll explain that. See, the right hand was showing an automatism where she was doing this. So this ipsilateral automatism often are ipsilateral to the lesion, and the extension and the posturing which was happening in the right arm is contralateral. So, and
Okay.
especially in frontal lobe seizures, what is described by Dr. Prakash Kotagal from Cleveland Clinic is the figure of 4. And this is typical for supplementary motor area which the girl had. And she had that typical figure of 4, that right hand is like this and right is like this. So this is like a typical figure of 4. This is 4. Can you see this 4 here?
Yeah, excellent.
So figure of 4. So that's what the extension of the arm tells you that it is contralateral. The flexion of the arm tells you that automatism and all is ipsilateral. So it is, that case was very highly localizing, and I showed you that sign where the lips are down like this. And that is known as capot the gendarme, means the smile of the policeman in France when he approaches you, when you have made some kind of a mistake on the roads, he'll come with that. So when that occurs, we are 100% sure that it's the cingulate. When we did the MRI, we saw it on that. The PET scan showed. So everything was falling in place. When in pre-surgical evaluation, everything falls in place, you have the best outcome. And she has not had a single seizure for 2 years. And she is doing so well in school. You saw her dancing, you saw her writing. Her speech has got completely, otherwise she was becoming slightly autistic at that point. So it's kind of a sort of game changer and lifesaver.
There are, I think, couple of other questions from Dr. Kripa Vijay, and very common question that what about use of midazolam nasal spray in controlling the febrile seizure recurrence, and uses of mefenamic acid plus paracetamol combination in a known case of febrile seizure for a temperate control? I think they are very common.
I think we
concerns
answered
and
that already. Yes.
Yes, it has been answered already. Dr. Nandan, what is the difference between nightmares and night terrors, and how do you treat that?
So nightmares are basically dreams, and we all get them. And they occur at all ages. Whereas night terrors are typically seen in young children, where they go to sleep, they wake up highly agitated, screaming, inconsolable. It can last hours together, and then suddenly they go to sleep when that night terror is over. And next morning, they will not remember that they were awake or what they did. So older children, when they get it, say 6-7-year-old or 5-6-year-old, they will not be able to describe what happened at night. They say, I didn't wake up at night, I slept quite well. So that is very typical of night terror. Nightmares we all get, so I don't have to tell you what a nightmare is.
So you don't need to treat night terrors also.
And you have to reassure them.
Yes.
Yeah.
Any?
Any other questions or comments?
Ram Gopal sir, kuch?
Nahin. I think sir has covered.
It was really very enlightening and very useful session, very lucid talk, and we are really privileged to have you, Dr. Nandan, for this first opening Learn from Legends event. And it was assigned to me to find out some legend, and the very moment I was told that, you came to my mind. So
thank you for thinking of me. It's been a great pleasure to have you as moderator and interact with all the stalwarts on the Maha IP forum. Yeah, I think we should interact much more whenever we're given the opportunity. And we are having the neurology conference in Goa later this year, I think sometime in September. So all of you are invited.
Thank you.
Thank you very much for the opportunity.
One important announcement.
Yes, sir.
Dr. Jain sir, we on 28th Wednesday we are launching one more program. that would be top. That is tips in office practice. Again, the concept by Dr. Bhavesh Mithia. So I would request everyone to join on 28th at 9 p.m.
And thank you, Dr. Bhavesh, for bringing such brilliant ideas to the IIP.
Our a pleasure, sir, to learn from all you legends. Thank you.
We are all learning, sir.
Yes.
Thank you, sir. I think we can conclude now.
Yes. Yes, Dr. Kashmiri.
Yes. So I would like to thank all the office bearers. First of all, our President, Dr. Ram Gopal sir, our today's leader, Dr. Jayant Jha sir, our moderator, and Dr. Bhavesh sir for giving this wonderful idea and for this wonderful program. And on behalf of MAHA-IP, I thank Dr. Nandan Yardey sir once again. Thank you, sir.
Thank you very much.
Thank you, sir. Pallavi
night,
madam,
everyone.
live
Good night.
live बंद